So different markets are going to handle this backlog, if you will, of all these elective procedures. Um, is there any indication of how Alberta's going to handle that?
Well, it's the perfect storm in Alberta, of course, isn't it? The perfect storm, meaning that Alberta was struggling already from an economic point of view,
Yeah.
and so there were very challenging times, and on so many different levels. But there is not a lot of. They were already talking about how they could cut back, on some of the services provided in a way that was still patient centric before COVID even came along. And of course, COVID appears on the scene. All of the structure went, and it was a lot of investment went into forming COVID teams and figuring out ways to deal with COVID. And then of course, now that COVID's going, there's this backlog of cases. They've had to very gradually open up the capacity. And I don't think there might be a plan from a surgical point of view, but endoscopy, it's really people trying to catch up without adding significant extra time, actually. And so
Okay.
I think we can do it. We have a pretty enthusiastic group of gastroenterologists, and so I think it can be done, but it's going to take time. There is a backlog for sure, and depending on what province you go to, they estimate some of the backlog. Like in BC, I think they estimate 1.5 years for surgeries, for elective surgeries. But
Wow.
Obviously, if you've been waiting for an elective surgery, then that it doesn't seem elective after you've waited another 1.5 years, right?
Now the backlog that's come through COVID, will there be an opportunity to further triage the waiting list that has developed?
Yeah, well, so the fascinating thing about COVID in Calgary, and I'm going to see, it'll be very interesting to see how this plays out. Is that so? When COVID started, of course, we weren't seeing anyone in our clinics anymore, essentially, unless you were urgent, really urgent.
Right.
And so what we had to do is we had to adapt to telemedicine, and this is not the traditional referral thing. And so we started to phone people. And it was fascinating because we would phone people even on our urgent list and say, hey, I'm calling you about the blah blah, and they go, oh, I haven't had a problem with that for 8 months, And so then you talk about COVID a bit, then that would be it, right? It was, and so they were still on the wait list, but they were actually not really having an active issue anymore. And so it's allowed us to really reflect on who's sitting on our wait list, and could we do other things. So we're starting to think about maybe other ways that we could do this. Maybe have nurses call who are trained in that area and say, hey, look, are you still having this problem? I mean, just something basic like that, right?
Yeah.
And if they aren't, then, well, that's fantastic. Well, maybe we'll just cancel your appointment, let someone else move in.
Yeah.
And the other thing is because there's a certain efficiency that comes with telephone consults. We actually did it. We were able to make tremendous inroads into our wait list. In fact, our wait list went. Our overall wait list now, if you include everything, not just our routine 0, but our wait list now was about 3,000 before COVID. Now it's 1,000.
Wow.
So we were able to actually do an amazing job, partly because fewer referrals were coming through, but also because the efficiency of this telemedicine. And so, I think we're starting at a lower number. And then we thought, okay, well, COVID's going to end. We're going to open up our because we have a central access and triage that processes all our referrals. I said, well, as soon as we open that door and people realize that's open, it's going to be flooded again. But interestingly, it didn't. It came up and it's kind of gone back up to where it went before, maybe just a little bit below that. So, I think there's something about the pattern of practice has changed, and I think time will tell us what it is. But it could, that could be the silver lining out of this, is that we might be able to be a bit more efficient in how we handle patients coming that are flowed through in a way that still makes everyone happy.
Yeah.
And so I'm quite excited about that opportunity.
Telemedicine has been around for quite a while, right? But it took something like this maybe to really demonstrate the value, funny enough.
Yeah. Well, it's funny because I have a friend who's a dean of medicine in the UK, and he said they've been pushing to try to do more online courses for the last 9 years. And he said that he said maybe they've had 2,000 meetings. They've had maybe one course go online. COVID hit, and within 2.5 weeks, all the courses were online. And he said, so it just shows you when you guys want to do something and they're motivated to do it, man, oh man, the sky's the limit, So.
Yeah, and you're right. We won't go back in many cases because we found a more efficient way. To do things.
And it might be a hybrid. I think it'll be a hybrid model in the end. And I think that there's some people that especially in Canada, which is such a vast country, having someone drive 3 hours for an appointment, when they don't really have to drive, they can just do it over like a Zoom chat or whatever. I actually think that's way more patient centric, and patients love it. They just love it, right? And so I do think it's I mean, some people want to see their doctor and they want to, and I think it's important for some people to have that personal face-to-face contact. But a lot of people are totally happy to have it all done by telehealth. So I think a hybrid, will suit. You can model it after whatever the patient wants. Really.
Yeah,